Hello. We'll start this in just a second. This is a presentation by seconddentalopinion.com. It's my teaching corporation. Who am I? I'm Fred Kornstrom. I'm a dentist. I'm also a flight instructor. The truth were known, I'd rather be flying today, but the weather's pretty lousy here in Seattle. So instead, let's talk about local anesthesia. Some have asked if they can get CE credit for watching these presentations. I think I now have 8 on YouTube. These are the same presentations that I've presented many times for various dental schools and CE programs. But realize this is being recorded in June of 2016. Things change, discoveries are made. It may not be valid next month, depending on what's discovered in the meantime. I am a clinical general dentist, and my emphasis is on information needed by clinical dentists. So this is number 107, local anesthesia. Am I qualified to do this? Well, I've been in practice. I'm starting my 53rd year. I hold a number of fellowships. I did a residency in general anesthesia after I got out of the Navy in about 1965. So I do have a fair amount of experience giving local anesthesia, and I've taught a number of courses. I think at last count I'm probably around 100, maybe 120,000 local anesthetic injections. So I've been around for a while. The first local anesthetic was cocaine. This was isolated from the coca leaves by Albert Niemann in Germany in the late 1860s. The very first clinical use of cocaine was in 1884 by Sigmund Freud, who used it to wean a patient from morphine addiction. It was Freud and his colleague Karl Kohler who first noticed the anesthetic effects of cocaine. Kohler first introduced it to clinical ophthalmology as a topical ocular anesthetic. In 1884, Dr. William Stewart Halsted was the first to describe the injection of cocaine into a sensory nerve trunk to create surgical anesthesia. You have to realize up until 1884, if you came to the dentist, and for some time after 1884, dentists were known for being able to extract teeth very quickly because short of having some alcohol or a little laudanum to numb your senses, there wasn't anything to block the pain of dentistry. How does this all work? Well, we have to understand a little bit about neural tissue, and this would be a cross-section of a neuron. And what it shows here, we all learned about sodium pump in physiology. Intracellular sodium is pumped out of the cell into the extracellular tissue. In turn, potassium is brought in, and there are pores here which let the potassium equalize the concentration against the cell membrane. These pores will not allow sodium in. So a nerve or neuron is a charged cell, and if it's stimulated, that charge can move down the cell by a process of depolarization. It's kind of interesting to me that we actually now know what those pores look like on a anatomic or molecular level, which to me is intriguing that they've worked it out to that level. So let's take a look at that neuron. If a depolarization sweeps down the neuron, here we have a pore with the positive charge extracellularly, and when that depolarization comes by, this gate swings open, as you see here, allowing the sodium to rush in to the intracellular tissue, and we see this spike in pH about 70 microvolts, and that sodium then triggers the next pore gate to open, allowing that sodium to rush in, and that causes the next pore to open, and in that way the depolarization sweeps down the nerve tissue cell. Signal transmission depends on a number of things. And one of the interesting areas is fiber size. The A betas are very large fibers, 8 to 12 microns in diameter. The A deltas, 2 to 4. And the C fibers are much, much smaller, you see down here. And these are the primary pain-carrying fibers that we dentists face every day. The A betas and the A deltas have a myelin sheath, which can be thought of much like the insulation around a wire, whereas the C fibers are only partially myelinated. If we look at the conduction speed, the A betas are very fast, 40 to 70 meters per second. They're largely touch, pressure, and proprioception. The A deltas are smaller, the speed is slower, primarily heat, cold, pressure, but they too carry pain. And then here we have the C fibers. The speed is much, much slower, and they're largely involved in pain, itch, and cold. Here's a picture of the neuron surrounded by the myelin sheath, and we have notorainiers here between the myelin cells. And in the case of the larger neurons, the depolarization goes from notorainier to notorainier, and that's why the signal is so much faster. And I guess in this case it was going that way. Here's our depolarization signal, while in the C fibers, it jumps in a much shorter distance, and so the propagation of this impulse is much slower in the C fibers. How do we stop this? Well, local anesthetic, and here we have a lidocaine molecule. One end is lipophilic, which means it's fat soluble, so that allows it to diffuse across the myelin sheath to get to the cell wall and across the cell wall. There's an intermediary linkage of chemicals here. And the other end is an amino group, which is hydrophilic, meaning it's water soluble, so it can dissolve in liquid in the cartridges that we then inject patients with. We used to think that local anesthetic molecule took up a position inside the pore, preventing the sodium ions to cross, and that way it stopped the depolarization. Actually, you probably have to stop several pores, or in the case of the myelinated fibers, several notorainier. We now think it takes up a location outside the pore, but nonetheless, it prevents the depolarization from continuing down that cell. Now, all nerve cells are susceptible to blockade, regardless of their function. Motor or sensory can both be blocked. Sensations will disappear and reappear in a certain definite order. The first thing to go is touch, and we know that after we've injected local anesthetic and we touch the patient's lip, they tell you it feels different. Next to be lost is the sensation of warm or cold, and then finally pain is the last, and it's very much like that nerve, considered looking a bit like an onion with these various levels. Touch goes first, then warm, then cold, and then finally the pain is blocked. The A alpha fibers are the largest afferent, largely from muscles and joints. They help motor function, moving arms, legs, etc. There is some proprioception signals telling us how much of our joint is bent. Reflex activity goes in these A alphas, and they're very myelinated. The A betas are a bit smaller. They're still very fast, but not quite as fast as a motor. They're afferent to and efferent from muscles and joints. Their actions, motor, proprioception, touch, pressure, and they're myelinated. The A deltas are much smaller, much slower, and now we're getting into heat, cold, pressure, and pain. And the C fibers are the little ones, and those are the ones that are largely involved with dental pain. They're the thinnest. They're sensitive to pain and temperature. They basically signal tissue damage, and they're unmyelinated. The C fibers, as I've stated, are either unmyelinated or non-myelinated. They're the very small nerves, slow transmission, dull pain and temperature, some postganglionic autonomic issues, and both the A deltas and the C fibers are predominantly the pain fibers, and they're blocked by the same concentration local anesthetic. So when we deposit our local, we'll get the A deltas and the C fibers. In general, small nerve fibers are more susceptible to local anesthetic than the large fibers. However, it depends on the type of the fiber, the degree of myelination, the fiber length, and to a certain extent by the frequency of signals that are firing down those neurons. And so that can change how susceptible they are. We're going to go back to some organic chemistry here, and I know this just excites you like it did me, and it took me a while to work through this morning. Local anesthesia consists of a cation, and that's the BH plus, and its base. Here's the base here, which is B, and it diffuses back and forth between these positions depending on the pH that the anesthetic liquid is being held at, and that changes depending on where it's placed. So there's an issue known as pK, which is that pH where half of the drug is ionized. So at a pH, half is the ion form, half is the base form. And the pK is fixed for each drug. However, the pH is variable depending on the tissue, and that changes the amount of whether the local anesthetic is in its base form or its ionic form. The base form will cross cell membranes. That becomes important because we've got to get across the myelin sheath. We've got to get across the membranes of the nerve. And the ionic form, the cation, is necessary to diffuse through tissue fluid. So let's take a look. We inject a solution of some local anesthetic that's pH is 4.5. That's pretty acid. 99% of it is in the ion form, and that's good news because it diffuses through the tissue. So we hopefully get it close to the nerve, but we depend on it diffusing through the tissue. When we get it into the tissue, the pH changes very dramatically. It goes from 4.5 to 7.3. So at that pH, 20% is base, 80% is the ion. Now it started out at 99%, now it's down to 80%. So this 99% went to be a little less than 20%. Now we come against the nerve sheath. In the nerve sheath, it's the base that crosses the nerve sheath. So if 20% of the original injection was base, that 20% can cross the nerve sheath, and because of the change in pH, it's now 7.0. This redistributes that 20% so that 15% is base and 85% of it is ion. And that's important because this 15% now diffuses across the next nerve membrane where the pH is 7.3. So that 15% then redistributes 20 versus 80. And what's happened as we did this, we lost the original, we ended up with 20%, so we lost 80%. That crossed over here, and we ended up with 15% of that 20%. And when it crossed here, we're down to 20%. So let's take a look at that. With a normal pH of 7.3, about a half a carpule, I'm going to say 1 cc. We'd have 16 milligrams of base, 16 milligrams of ionized form, 4 milligrams of base in the 80-20 mix. After it crosses the nerve sheath, that changes, so we only get the 20% of the base, and so we're now down to about 0.4 milligrams of the original local anesthetic, or about 10% when we get down to this level, 90% being in the ionic form, and that's with a pH of 7. But let's take a look at what happens if we're injecting into inflamed tissue, an area that's infected. And so the pH is now 6.5, so this is distributed a much different ratio, 94 to 4%. Once it's gone through the nerve sheath, we're now down to 0.08 milligrams of local anesthetic, which explains why we have a hard time getting people numb if they're infected and have inflammation. The principles of local anesthetic, the duration of action is directly proportional to protein binding and to lipid solubility. Diffusion away from the site is caused by the vascularity of the site, how many capillaries there are, how much blood flow is going through. That's how we get rid of local anesthetic, is have it diffuse away from the site where we injected it. The protein binding, in other words, if it binds to the proteins in the area, then it stays longer, and that will increase the duration. The onset of action is directly proportional to the pKa. And it now enters the vasoconstrictors, because if we use pure local anesthetic, it doesn't last very long. So the primary rationale for vasoconstrictors, it increases the duration of effect. And the mechanism, the alpha-1 stimulation, causes the arterial constriction. The capillaries constrict, and so less local anesthetic is washed out of the area. The second rationale for using a vasoconstrictor is if we inject it without the vasoconstrictor, the local anesthetic would diffuse into the circulatory system much faster, and there would be a greater chance of having a toxic reaction. So with some vasoconstriction, it reduces the systemic toxicity because it decreases how fast it's absorbed. So for a given dose, it'll be absorbed into the circulatory system over a much longer period of time. And the third reason is we get a decrease in bleeding. By constricting the capillaries in the area, we get less bleeding, which makes it easier to work in the area if we're doing surgery. But the thing you have to remember, and I've been caught on this a couple of times early in my career, I got a call that someone had an extraction, and they were bleeding. It was bothersome. They were spitting out clots of blood. So I said, well, come on back up to the office, and I'm going to resuture, put some more pressure in the area to get that stopped. They get to the office, and indeed it's oozing a lot, and they're not going to bleed to death, but it's worrisome. So I got to numb you up if I'm going to be able to put some more sutures in here. I numb them up and the bleeding stops. And in my younger, dumber days, well, that's great. There's no reason to suture more. We just solved it with a local anesthetic. And the problem is, once the local wears off, in fact, we get a rebound effect, so that we get the dilation of the capillaries, and a couple hours later I get another call from them. Hey, I'm bleeding again. So I learned quickly, even if they stop bleeding, do put the extra sutures in to be sure you got it stopped. Oftentimes you'll get some tachycardia from the vasoconstrictors. The beta-1 stimulation causes the tachycardia. You also get some peripheral effects. The alpha-1 stimulation causes arterial vasoconstriction, and that can cause an increase in blood pressure, heart rate, and cardiac output. We worry a bit about that in cardiovascular patients. Is there a risk due to medullary epinephrine release greater than the risk of the epinephrine delivered by the local anesthetics? And over the years, I've come to the conclusion that I'd rather not hurt the person. If I hurt them, they're going to get more molecules of epinephrine into their bloodstream than they're going to get from a local anesthetic if I'm using a 1 to 1,000 or 1 to 100,000 dilution of vasoconstrictor. I always sort of wondered, how did we get how many micrograms? So this is a little quick discussion of that, referring to the epinephrine that's in the xylocaine 2%, it's 1 to 100,000. That means there's 1 gram of epinephrine in 100,000 milliliters, or 1,000 milligrams in 100,000 milliliters, or 1,000,000 milligrams in 100,000 milliliters, or 10 micrograms per milliliter. And if the cartridge is 1.8, now they're 1.7 for the most part, that would be 10 micrograms per millimeter times 1.8, or 18 micrograms per cartridge, which is how we figure that out. Cardiac patients, I've been told, try to avoid locals. If you ask their physicians, oh yes, I don't want them on any vasoconstrictors, what they don't understand is just how little vasoconstrictor enters the bloodstream when we give it in our block. Now that's assuming you use 1 cartridge. If you're one of these guys or ladies that gives 5, 6, or 7 cartridges to get a tooth numb, you're going to be increasing the amount of epinephrine getting into their bloodstream. Typically, the literature says you want to not go over 40 to 50 micrograms of epinephrine in cardiac patients. So that still gives you two, maybe three cartridges, and you're fine. In non-cardiac patients, it's more like 200 micrograms. So should we use epinephrine or not? If the patient can walk, do light yard work, raking leaves, weeding, pushing a power mower, painting, doing light carpentry, local dental anesthesia up to 1 to 80,000 can be administered safely. Some question about how much epinephrine we have in our retraction cord. I had a friend, I use the term kind of loosely, that really got on my case about that. Fred, you're going to kill somebody using that epinephrine cord. And they'd done a study at Oregon where they placed retraction cord and then had the patient continually spit in a cup as they developed saliva. They were to spit it in the cup, and when they were done, they pulled the cord and put it in the cup. And then they analyzed the saliva and the cord to see how much epinephrine was there, and they claimed all the rest of the epinephrine had been absorbed. That was a pretty healthy dose of epinephrine if it was all resorbed and if they didn't have swallowing some of it. I knew it wouldn't work, but I decided, okay, I'll give it a try. I went to non-epinephrine cord knowing I wouldn't be able to get a good impression. Actually, it worked just as well, so he did manage to get me to switch. I did call, as a Park Hill company that we were using their cord at the time, to see if they'd had any lawsuits from people dying of it, and he said no. And we would certainly be the first to hear because we've got much deeper pockets than you do. And in fact, in studies where they've looked at blood pressure changes in the oral surgery office after local, they see 8 millimeter of mercury rise in pressure of the systolic and about 1 millimeter in the diastolic. For restorative dentistry, there was a study that showed 4 and 3. So it's really pretty minimal. The actual administration may raise the blood pressure while the needle's in the mouth. But in general, once it's removed, the transient increase decreases. It doesn't completely go away. Let's do the same thing about the concentrations of lidocaine, because we have a tendency to say I gave 1 cartridge or 2 cartridges or 3.5 cartridges. Well, how many milligrams of lidocaine was that? So if we're using 2% lidocaine, that means there's 2 grams in 100 ml or 2,000 milligrams in 100 ml, which means there's 20 milligrams in 1 ml. If your cartridge is 1.8, that would be 20 milligrams times 1.8, or about 36 milligrams per cartridge. 2% lidocaine with 1 to 100 to 1,000 epinephrine is by far the safest local anesthetic we have. Maximum dose for children is 1 cartridge per 20 pounds, or approximately 10 kilograms. Very, very safe anesthetic, but if you've got a 40-pound child, you can only give a couple of cartridges of any local anesthetic, and xylocaine is the best one. You can't do all 4 quadrants and have 4 cartridges in there on a 50-pound child. You're going to be pushing the toxic dose. We also have some local anesthesia plants. The one on the less supple jack, I'm not about to try to pronounce that word, was used by Aborigines in Australia to make a remedy for toothaches. It grows from Sydney to North Queensland. The tips of this plant wrap around other plants that you see here, and in that way it's able to climb up trees. It's a parasite. The Florida Indians and settlers chewed on this vine to cure toothache, which grows all over the Everglades. So there are some natural, in addition to cocaine, local anesthetics. We think that's blasé now to have them chew plants. So we have these 2 cartridges here that started out at 1.8 cc's per cartridge, and most of them are now down to 1.7. And there are some colored bands on these which correspond over here to the colors you see. So 2% xylocaine with 1 to 100,000 is red. The marcaine, pipivacaine down here is blue. The light blue, oh, we said that already, is plain lidocaine. So you can tell by the color code what carpule you have in your anesthetic. There's 2 main chemical classes. The esters we'll talk about first. These include cocaine, which no one uses. Procaine, I shouldn't say no, and it's still used in some ENT procedures because it's a uh, vasoconstrictor. Most of the rest of the local anesthetics by themselves tend to be vasodilators. Procaine, which is the original Novocaine, I've never used it. Tetracaine is oftentimes used in eye surgery. Chloroprocaine, I've never used. Articaine, also known as septicaine. These are all hydrolyzed in the plasma by pseudocholinesterase. One of the byproducts is para-aminobenzoic acid, which at one time was a preservative agent found in local anesthetics, and that's where we saw most of the allergic reactions that were seen in local anesthetics. So that's possible with the esters. The amides are the other large group, which includes lidocaine, bupivacaine, known as carbocaine, prelocaine, known as synetest, bupivacaine, known as, I'm drawing a blank, it's a long-acting one, marcaine, and endocaine, which is Duranest. They are metabolized in the liver to inactive agents, and true allergic reactions are very rare, especially with lidocaine. Because I saw many, many fearful patients, I had a lot of people come to me and tell me they were allergic to all the local anesthetics. Well, that's a little bit like being allergic to buttermilk, hubcaps, and the American flag. They're chemically very different formulas. But if they told me they're allergic to it, I'm not going to take the chance. So I'd send them off to the allergist. And I don't know, we probably sent a couple hundred off. They actually found two patients that were truly allergic to xylocaine, and it wasn't due to the methylparaben that had been the preservative agent in them for many, many years. That was removed, I'm going to say 30 years ago, but don't put that on the test. At any rate, the allergist called me, says, Fred, if you can find me one more true allergy to lidocaine, we'll write you up for our allergy journals. It's just unheard of. I've never found another one, so I didn't get written up. So let's take a look at them. Here's bupivacaine, which I never can remember. It's also known as marcaine. It's 0.5% solution, 1 to 200,000 epinephrine. So it's got much less local anesthetic, much less epinephrine. Pulpal duration 2 to 5 hours. Soft tissue duration 6 to 12 hours. This is a drug I like to use after I've done oral surgery if I've had to lay a flap and I know there's going to be a lot of swelling. Before the patient leaves the office, we give them 600 milligrams of Advil, and we know that that's going to hold them for about 6 hours, but it's going to take a while to kick in. And tell them in 6 hours to take another 600 milligrams, because this will keep them numb through the first 6 hours and maybe the second 6 hours. And by then we've got the Advil on board working, and if you do that every 6 hours by the clock, it's exceedingly rare for anybody to have any pain from dental surgery, and you don't need to go to the narcotics, the OxyContins, etc. Vasoconstrictor per cartridge is very low. Maximum dose is about 10 cartridges. Well, you ought to be able to get a whole lot of the mouth numb with 10 cartridges. I can't imagine using that much. Bupivacaine or carbocaine is the next drug we're going to look at. It comes as a 3% plain, and look at the difference. 30 minutes of pulpal, 2 hours of soft tissue. You can give 5.5 cartridges because this is a 3% solution. It also comes in a 2% with neocobephrine, and that's got better pulpal duration and fair soft tissue duration, so that's a good choice. The neocobephrine is less of a threat maybe to the heart patients, particularly those of us that are sensitive to epinephrine, what I am. I don't see that my heart beats faster with the neocobephrine, and you're limited there with 8 cartridges. Now my favorite, lidocaine, xylocaine, octocane, whatever you want to call it, 2%, 1 to 100,000. I got 60 minutes of pulpal anesthesia, 3 hours of soft tissue anesthesia. I could give up to 12 cartridges before I met the maximum dose. That's a ridiculous amount of local anesthesia. You better think a little bit about your technique if it's taken 12 cartridges. It also comes with a 1 to 50,000 epinephrine, which at one time, I think in dental school, I learned I should use if I was doing surgery because there'd be less bleeding, which is true, but you can see how many more micrograms of epinephrine you have, and that in turn decreases the number of cartridges you can use, not because of the xylocaine, but because of the amount of epinephrine. Articaine, which is everybody's favorite drug at the moment, also known as Septicaine, is a 4% solution with 1 to 100,000. I think it comes to 1 to 200,000. 60 minutes, 3 hours duration. Supposedly, uh, it wears off a little faster. It is an amide, so it's broken down not by the liver, uh, but the maximum dosage is 6 cartridges because of the 4% solution. And we'll talk a bit more about this, but there's a very significant risk of temporary or possibly permanent paresthesia to this anesthetic. And it's probably due to the 4% concentration. When they put these drugs, xylocaine 2%, 4% articaine, on neurons, I think they got the neurons from some fish. At any rate, it's a lab bench sort of study. The 4% concentration is much more toxic than the 2%. In fact, if they use 4% solutions of both, the 4% articaine is a little less toxic than the 4% xylocaine, but we never use 4% xylocaine. I've been involved with a number of malpractice suits where articaine was injected. In one case, a hygienist injected it to do a block for a lower arch to do the cleaning. The patient jumped, indicating she probably pierced the nerve with her needle, but she injected anyway. So she injected right into the neuron as opposed to around the neuron. And that was the last thing the patient felt in his tongue. 4 years later, his tongue varies between numb as a post and feeling like it's on fire, and it's probably never going to get any better. In another case, the dentist, by giving massive doses of articaine, managed to damage the facial nerve, and a beautiful young woman suddenly has her right side of her face go into muscle spasm about every 20 or 30 seconds. They can block it by blocking the facial nerve with Botox. The problem is then she can't close that eye, she can't smile, that side of her face is paralyzed. I would be very careful using the 4% solutions. Here's a study that was done by Haas and Lennon. They looked at 21 years retrospective study reports in Canada following local anesthetic. And if we look at articaine, there were 50 cases of paresthesia, that 4% concentration. The frequency of paresthesia was about 1 in 200,000. That's very good. I've only given 120,000 injections in my 52 years, going on 53. So that says that's about 2 careers to get a paresthesia. But let's look at the other things. Marcaine or bupivacaine, 1 in 1.5 million. If we look at xylocaine or lidocaine, it's 1 in 4.4 million. So this is about 20 times more likely than lidocaine. And bupivacaine, again, this is a carbocaine, about 1 in 3 million. The other issue was a 4% prilocaine, which is about 1 in 300,000. So the two 4%ers see much more paresthesia than the other local anesthetics. I think that's a big enough problem. You probably need an informed consent. You need to tell the patient, I want to use this more concentrated anesthetic that I think is better, but you got to realize if I use it, you're 20 times more likely to either have that part of your face or that part of your tongue numb the rest of your life. If I were a patient, I probably wouldn't buy into that action. This is a great chart. It was done by Rose Yeager. She's a registered dental hygienist in Wyoming, and she went across and took all the local anesthetics and calculated the maximum dose depending on the patient's weight. The parentheses here are from Stanley Malmed's writings. This side here that doesn't have parentheses is from the manufacturer. So You could use 11 cartridges on a 200 pounder and not be approaching the toxic dose of local anesthetic, which in this case is 400 milligrams for 2% xylocaine. She also did the same thing with the various concentrations of local anesthetic. If you use this chart, and I'd encourage you to use it, uh, feel free to email me. I'll send you a copy of it that you can print out. And please email Rose and tell her thank you. She put a lot of work into this. The toxicities of local anesthetic. Essentially, all systemic toxic reactions associated with local anesthetics are a result of an overdosage leading to high blood levels of the agent that was given. Therefore, to avoid systemic toxic reactions to local anesthetic, the smallest amount of the most dilute solution that effectively blocks pain should be administered. It's the pharmacology mantra, go low, go slow. Use the smallest amount of the least concentrated, and you'll get into trouble far less. Signs of toxicity occur on a continuum, the early stages to late stages. These signs are circumoral or tongue numbness. That's what we're looking for. Lightheadedness, tinnitus, buzzing in the ears, visual disturbances, muscular twitching. Now we're starting to get into the bad stuff where you see convulsions, unconsciousness, can lead to a coma, respiratory arrest, and then cardiovascular collapse. When I was first in the Navy, there was a uh, problem in the operatory next to the one I was in. Like curiosity got the best of me. I walked next door, and here's a Marine in full-blown grand mal seizure. They'd called the medics that were across the hallway from us to come give him a hand. The chair was leaned back, and this guy was having a full-blown grand mal seizure. Then another young dentist who had just come into the Navy was there. He said, "What the heck happened here?" He said, "Well, I think we're seeing a toxic overdose of local anesthesia." And the dentist said, "Well, gee, I only gave him 8 cartridges." And the fellow I was talking to said, "Yeah, that was after he gave him the 8 that I have here in my hand." Uh, Fortunately, they were able to stop his convulsions and took care of him and with no ill effects. But when you start to see muscular twitching, certainly if you get into convulsions, we don't see these things in a general dental practice, even in a surgery practice. It's time to get on the phone and call 911. You need all the help you can get as soon as you can get it. So we did a little study. We looked at a group of patients. The mean age was 40. We gave them an apprehension score to see how apprehensive they were. Had them describe their pain from previous injections. How do you do that? You take a 100 millimeter line, and on one end you say no pain, on the other pain, the worst pain you've ever experienced. It was a small study, 14 men, 7 women. Because of the fact that I practice in a multiracial area, we had a pretty good uh, across the board distribution of various races and ethnic groups. Uh, we only took ASA1 patients. You're going to have to watch the previous video. It's American Society of Anesthesiology criteria, which a class 1 patient is a normal, healthy patient. We didn't use anybody with cardiac pacemakers, no one with a seizure disorder, history of aneurysm, history of cerebral vascular accident, stroke. They couldn't be pregnant, and they had to be between 16 and 70 years old. And what we were doing is we were using electrodes here from a TENS machine to replace topical anesthesia while we inject it. And so here you see the electrodes. I'm holding those much like you'd hold chopsticks. They're about 10 inches long. And you want the electrodes to really be on either side of where you're going to put the needle. So this electrode should have been over here a little further. And then we ask them, we use topical anesthesia on one side, and we use the electrical anesthesia on the other side. This end of the line now is I strongly prefer electronic anesthesia. The other side, I strongly prefer topical. And this is a box plot. 50% of the people fall into the box here. This is the mean or the average score. And out here we have the outliers, 25% out here, 25% out here. If the patient said it was the same, or they preferred the topical, that would be 25%. 75% preferred the electronic anesthesia. Now, I questioned these folks out here, was the topical less painful than the electronic side? And they said, no, no, I actually had less pain with the electronic side, but I didn't like that electrical feeling. So it told me that that might be a better way to pre-numb people before we give an injection, is using the TENS machine rather than topical. It works better. The next interesting sidelight to this was a Stabident company came out with an easy way to do intraosseous injections. And here you see we have the needle, and when you open it, it's got a very, very short needle. I'm going to say about 4 millimeters long. And this is a perforator that fits in your low-speed handpiece, and it's basically a needle without a lumen. So what do? Well, we put that on our low speed, and here's our needle on our syringe. And the first thing you got to do is put a drop of anesthetic in the tissue before you try to perforate, because that's going to hurt. And here you see our TENS devices so that you don't feel that injection. You then take your handpiece and you perforate between the roots of the tooth that you want to get numb. So if we want the bi, I'd probably put it on the distal of the bi, but if I go on the mesial, it'll work also. This would work great for the cuspid. And you want to perforate in the attached tissue, because if you don't, you will have a terribly difficult time finding the hole in the bone. So once we've perforated, you don't take your hand or your eyes off of this site. You hold your handpiece up, and the assistant puts the syringe in. You see this little dot of blood, that tells me where the hole is, and we slowly slide the needle into that hole, and then we inject very, very slowly, because essentially you're injecting intravenously if you're in the marrow space. And usually half a cartridge is plenty. I tended to use anesthetic that didn't have local anesthetic, but because being an intravascular injection, that epinephrine will cause a tachycardia. So here's where the needle is, intraproximal. You really don't want to bump into the root. And this is my little study. Once I'd done the injection, I took a pulp tester and put it on the tooth, and every 30 seconds would get a reading where 64 is totally numb. So with an infiltration here, I found that a very high percentage of people were numb 3 to 3.5 minutes. But there was one that was clear out here 7 minutes before they got numb. These lines are one standard deviation. With the block, it took a long time to see any effect, 5 to 6 minutes. And most people were numb at about 7 to 8 minutes. But it took that long, so don't get impatient. You give a block and they're not numb at 4 minutes, well, we didn't expect that. But look at what happened with the interosseous. I only had one patient that I could get the pulp tester on the tooth quickly enough to get any response at all. But at 1 minute, they were all numb. The pulp tester went to its maximum of 64. So it really did work, and it worked really quickly. Now in the block, we did have one block that failed. Intraosseous, they all had anesthesia within 1 minute. At half a minute, I caught one that wasn't completely numb. This is kind of an interesting concept that we're beginning to see. These are little mini vibrators, and there's a hole on the end. You put this end on the tissue where you're going to place the needle and turn it on so it vibrates, and then you put the needle through into the tissue. And that'll block most of the pain of piercing the tissue. You still have to inject slowly once you get through the tissue. Now let's talk about something I didn't learn in dental school, maxillary second division nerve block. And I'd heard of it. I was always a little nervous about doing it. It turns out it's really not that hard to do, and it really works pretty well. What does it get? It gets everything from the central back to the third molar numb. Now you do get some cross arch sensitivity here, so if you're working on centrals, you might have to infiltrate. What's the technique? Well, you find the soft spot over the pterygopalatine canal leading to the pterygomaxillary fossa. About 90% of patients, it's on the distal one half of the second molar to the mesial one half of the third molar. about halfway between the midline and the lingual of that molar. So what does that all mean? Well, here's our third molar, here's our second molar, here's the midline, here is the middle of the palate, here is about where the tissue would be. So halfway between the midline. If you probe with your finger, you usually will find a little depression in that spot, or you can use a Q-tip, or your glove finger, of course, now, and you're going to try to thread the needle up that canal. So here I am with the Q-tip. Here's the second molar. There is no third molar in this patient. Is that true? Yeah. Okay, this is the second bicuspid. And so I'm a little distal to that, and here is the midline of the palate. I could feel a little depression. You peck with a needle until you find the foramen. Get through the tissue and give a drop of anesthetic, and then you can redirect your needle a little bit. And you want to advance the needle 2.5 to 3 centimeters up the canal. The canals are angled, and this is a study done by Stan Malmed. Less than 35 degrees, 12%, 35 to 42, 27, 45 to 47, 17, 32 were 50 to 57. So between here and here is about the right angle, which is about 45 degrees. So this needle would be coming from this direction to get down the canal. So the technique, find the soft spot, find the foramen with the needle, advance the needle 2.5 to 3 centimeters, aspirate and inject slowly, 1/2 to 1 cartridge. It doesn't take much anesthetic to do this block. Problems that I've known trying to do this. Well, I couldn't find the canal. Well, you keep pecking with the needle, and you'll find it if it's there. Then I found it, but I can't get down the canal. Change the angle of the needle, and in general, you're probably going in perpendicular to the palate. You want to be more to 45 degree. I still can't get down the canal. I found it, but the needle won't go down the canal. Well, this is a point where you can inject over the orifice and just put your thumb up there and hold pressure. That'll force the local anesthetic down into the canal, and I've used that with success. Or I can only get part way down the canal. In this case, I'll rotate the syringe to rotate the bevel of the needle so that I can change the bevel of the needle in that direction. And that usually gets, and if I still can't get down, just inject slowly at the furthest penetration. It'll diffuse down and you invariably will get the block. So it's very easy to do. I really don't understand why they didn't teach it to us in dental school. You get the whole upper half of the maxilla. And, some problems are solved more easier than others. I like this cartoon. Okay, rinse. Is there anything I can do to make my teeth look whiter? Yeah, you could start wearing a dark shirt. That'll work, or get a tan, or start wearing dark lipstick. When women went to natural shades of lipstick, it very nearly drove me crazy because every woman that came in told me how yellow their teeth were. Well, their teeth hadn't changed colors. What had changed colors was their lips, and the contrast just wasn't there anymore. So no one is 100% successful, not even me. I occasionally have one of these that I go back and do an infiltration. So let's talk about what sort of an emergencies you can have from local anesthesia. What is an emergency? Any condition, if left untreated, may lead to the patient's morbidity or mortality. We don't want that. And in my case, it's any condition of the patient that raises my blood pressure or my pulse rate. The Boy Scouts were right. We got to be prepared for all these shortcomings. Best preparedness is prevention. Know your patient, get a complete medical history. Are they allergic to something? Find out about it. Review any areas of problems, cardiac problems in particular. Have a good medical history. Mine's probably a little too complex, but I'm happy with it. And have them circle, and you take notes. If they're allergic to something, write down. I write in red. The one you don't want to see, here's one that's had a heart attack. He's got a heart murmur. He's had rheumatic fever. He's had hepatitis A, B, and C. You sort of hate to see all those, but you'd like to know about it. And then at the bottom half of my record, after they give me a list of all their drugs, we get their blood pressure, and we have them sign, and then I initial it and date it proving that I read their medical history. And that is important if you ever have a problem. Yeah, you got a medical history, but did you ever look at it? Well, that's sort of proof you did. How do you become prepared? Well, you take training and you practice and you practice and you practice. And it's nice to have a manual with simple flow charts, what to do. In general, the less equipment you have, the better it is, but you want to have all the equipment you know how to use. Your cell phone is a big part of your emergency practice. You can call 911 and stay with a patient and uh, tell the operator what sort of an issue you're having so that when the paramedics get there, they've got an idea what's going on. You need some medication in your emergency kit. We covered that in the medical emergencies and dentistry video, but only have the drugs that you know how to use and are willing to use and the ones that you're comfortable using. Now, when I came out of my anesthesia residency, I had a whole tackle box full of drugs, and over the years, I've gotten that down to about 7 drugs. Some of the drugs that I learned to use can be dangerous if used wrong or used on the wrong patient. So as the years went by, I got rid of those. Needle breakage is a local anesthetic complication. How does that happen? Well, the sudden or unexpected movement of the patient is what causes it, but we're responsible for using finger rests so that if they move, our hand and needle and syringe move with them. Small needles are the ones that are most likely to break. Uh, the biggest needle I use is 27 gauge, and I pretty much use that for everything. There are people who believe you should only use a 35 gauge. Those are getting pretty big. And there's been at least one study to show that they don't hurt any more than the 27 gauge. But use longer or use larger needles and never hub a needle. I've read people using 31 gauge and they inject it clear to the hub so they can use a block, and they like the little needle because it hurts less. Well, it really doesn't hurt less. But if you hub a needle and they move and your hand doesn't go with them, that's when you're going to break the needle off, and it's in the tissue and it disappears. So never hub a needle. Management, if there's even a wisp of a needle sticking out, tell the patient, don't move, don't open, don't close, hold perfectly still. Ask the assistant to give you a pair of hemostats and pull the needle out at that point. If the needle disappears, they can be very difficult to find, and you need to send that patient off to an oral surgeon to go hunting for it. And it's a pretty big deal. Those needles can move around a lot, and if you think about, particularly in the block, well, in the infiltration also, there's a lot of very delicate tissues there that needle could disrupt. In the block, you've got major vessels and arteries there in the neck, could even conceivably get back as far as the spine. Infiltrating over cuspids, it could migrate up and damage the eye. So you don't wait on this one. You get them off to somebody who can go after it. The other one is pain or burning on the side of the face. How does that happen? And this is kind of a light chart, but you're going back here to get the infraalveolar nerve. If you go a little bit further and inject into the inferior alveolar artery, remember the artery is taking solution out to the local areas, and you get into that, all of a sudden this whole quadrant here can turn just snow white as a vasoconstriction of the epinephrine gets in there. Burns like heck. It scares the devil out of the patient. I've seen this happen once. How do you avoid it? Well, know where you're going and don't inject unless you touch the bone of the mandible, because if you're the wrong angle and you go out the back and you get it into this artery, you can cause problems. The other area that's out there that you can screw up is the facial nerve, which is in the parotid gland in that area, and you don't want to be injecting into the facial nerve either. So it's pain, the rate of the injection was too fast, or the artery would have backfilled into your needle. The pH of the solution is acidic, and you're doing an intravascular injection into the artery, and so it's going to go to that section of the mouth. Prevention is technique, technique, technique. Pay attention. There really is not much you can do after you've done it other than to give it time, and it typically wears off in a few hours. Other complication, persistent paresthesia or amnesia. It's caused by trauma to the nerve. In the old days, we were taught to keep our cartridges in an alcohol bath. Well, if you happen to have a crack in the glass, you could get alcohol into that, and that was believed to be the cause of some paresthesias. Uh, when you inject, if you happen to nick a blood vessel and leak blood into the area, you can get hemorrhage in the area. The biggest cause today is the 4% solutions when used for mandibular blocks. And that's largely Articaine. Everybody knows Articaine is a better, stronger, more profound local anesthetic. But remember, it's got more than a 20 times greater chance of leaving the patient numb for the rest of their life. The solution, again, comes to technique. Most of these are self-limiting, and they will go away after about 8 weeks. Most common in the inferior alveolar or the lingual injection. I've had it happen once. I saw the patient the next day, and every 2 days after that, for a couple of weeks, mapping the area of paresthesia. By the third or fourth day, the area was starting to get smaller, and I was beginning to breathe again. If you don't see any improvement after, say, 2 to 3 weeks, definitely at a month, get them off to an oral surgeon. There are some surgeons that can reanastomose those nerves with some success. It's hardly 100%. Trismus, this happens every so often. Uh, if you get into a muscle or a blood vessel and you get blood into the muscle, you get a bruise. And contamination of the cartridges, I've never heard of that since we stopped bathing them in alcohol. You could get infection, I suppose. I've never seen that. But you basically end up with a really sore muscle. The prevention is always use sharp needles. And if you touch the bone with it, you need a new needle. The technique, keep penetrations and volumes to a minimum. So you don't want to be going back in there 5 times and putting in 3 cartridges to numb up one tooth because they get numb faster if I give them 3 cartridges. Well, I hope so. You put enough in there to numb up a horse. Management, examine the patient, record how wide they can open their mouth, where the pain is, and you can have them use a hot pad or a hot water bottle. If it continues, you can get them to a physical therapist. And that's usually all that's necessary. I've never had to use a muscle relaxant. Hematoma, where you nick the blood vessel and it bleeds rather into the superficial tissues. Of course, that leaves the patient looking like they got in a fight with this black and blue area. The person that's most likely going to happen to is your front desk person. So they're up at the front desk the next day with this big bruise on their face. Well, how did that happen? Oh, the doctor numbed me up. And then, it takes a couple of weeks to go away. At first, it's a blackish color, and then it goes to green, and eventually to yellow. And it's particularly if it's your front desk person, it seems to take forever. So how do you avoid it? Know your anatomy, minimize the number of penetrations, aspirate before you inject in case you're in a blood vessel. Hold direct pressure on the area if you realize it's happened. You usually don't until you get a call the next day. A couple of minutes wouldn't hurt to put an ice pack on, and it may last for 10 days unless it's your receptionist, and then figure 3 weeks. Lip chewing is caused by our long-acting local anesthetics, particularly with children or handicapped that chew on their lips. Kind of works if you put a cotton roll between their teeth when they leave the office and tell them to bite on it for the next hour or so. Realistically, I don't think many of them do. Management is basically symptomatic. Advil for pain. Assure mom that they're okay. It's going to heal. And, I've had mom bring them back the next day. Their lip looks like hamburger, and it's really sore. And sympathies about the best thing you can do for that. Facial nerve paralysis. What's the cause? Well, when we inject, here's our ramus of the mandible, and our needle's coming in parallel to the occlusal plane. And if you come in from the anterior teeth, you're shooting for the inferior alveolar nerve. Here's the artery and inferior alveolar vein. And then back here in the parotid gland is another vein and an artery. And way back here is the facial nerve. and that's the one you don't want. Well, if you're coming in this way, you're not going to bump into the bone, and you could very well get into the parotid gland and nail the facial nerve. The technique is come cross arch. So that's the direction if you're coming from the anterior. If you come from the other sides bicuspid and come across, you're going to be right in the correct area for the inferior alveolar nerve when you touch the bone. So don't inject until you touch the bone. Do they feel it? Yeah, they do feel it a little bit, but not too much. And then you know where you are. Uh, no anesthesia in the inferior alveolar. Uh, with muscle weakness, first reassure the patient they're going to be okay. It'll go away when the local wears off. They may want to have them remove their contact lens if they're unable to close their eyelid, which if you got back here and nailed the facial nerve, they won't be able to smile on that side. They won't be able to close their eye. You might want to patch the eye to protect it and assure them it should go away in a matter of 4 hours. Now, one of the cases I've been involved with, they were actually infiltrating an upper bicuspid, and they got so far out into the tissue, so far away from the bone, that they nailed the facial nerve, and he gave 3 cartridges of articaine, which is enough to get half the face numb. But unfortunately for this lady, they got it into the facial nerve and destroyed the facial nerve. Caused a lesion there that continually fires, and about every 15 to 30 seconds, that side of her face goes into spasm. Very disfiguring. This is a very pretty lady. And when they paralyze the facial nerve with Botox to stop the twitching, it really ages her. She looks like she's in her 50s rather than in her 30s. Local anesthetic overdoses several minutes after injection. The patient becomes rigid. They may have a seizure. What do? Well, lean the chair back, get their feet elevated in the Trendelenburg position, maintain their airway, look, listen, and feel. Be sure they're breathing. Get their vital signs. And what's the treatment? Well, know your maximum doses. Get Rose Jaeger's chart and mount it in every operatory. If you get to the point of having seizures, call 911. You're in big trouble and you need somebody there who can help you. You wouldn't be wrong to put a full face mask on with oxygen, but if they're seizing, it's going to be really tough. And you probably need to terminate that appointment. Now, this is not the reaction that you get from the epinephrine. There are a few people like myself that are sensitive to the epinephrine, and I'll kind of get the shakes after 1 cartridge. And I can feel my heart kind of tachycardic. But that goes away very quickly. The half-life of the epinephrine is very short, a couple of minutes. Fainting, lightheaded, weak, pale, sweating, rapid breathing, rapid pulse. Again, position the chair, get them horizontal with their feet elevated. That can be a problem if they're pregnant. If they're pregnant, you may want to lean or rotate them so they're on their side, because if they're on their back and they got the baby sitting on their inferior vena cava, their heart pumps blood down to their legs, but it can't get past the baby's pressing on the vena cava, and you pool the blood in the feet, and pretty soon they get lightheaded. You want to be ready to open their airway with a head tilt, chin lift, and look, listen, and feel. Be sure they're breathing. If you can't get a blood pressure, check their carotid pulse, and if the carotid pulse is the only pulse you get, it's time to call for help. So if no pulse, or if it's only a carotid pulse, call 911 and be ready to do CPR if they have no pulse at all. Put them on some oxygen. That's always a safe thing to do. Monitor their blood pressure. Watch for a trend. If it starts coming up, it was simple syncope. Consider it might be hypoglycemia, particularly if this happens right before lunch or right before going home time when they're getting ready for dinner. But just because they feel better, don't set the chair up quickly, because they may pass out for you. I found this with the Marines in my first month in dentistry. I wasn't very good at hiding the needle. And you have these big 220-pound, physically absolute fit individuals sit down in your dental chair, wave a needle in front of them. The bigger they are, the harder they fall, and they faint. Lean the chair back, and whoa, they come around. They're feeling better. Set the chair up, and they'll faint for you again. So keep them horizontal 10 to 15 minutes. depending on what you're doing and how severe the reaction was, you probably ought to quit for today. You've had enough excitement as they have, but keep them around the office for, an hour or more, because they don't recover from this sudden drop in blood pressure that quickly. They're going to feel better, but they're a long ways from being normal. Allergies with our local anesthetics, particularly if you stay away from the amides, it's going to be exceedingly rare. I've never seen one, but a rash, hive, itching, slow in onset. Uh, what do? You keep them comfortable, ask them if they're having trouble breathing. They're okay. Get their vital signs, blood pressure, etc. And Benadryl is sort of the drug of choice for the slow onset rash and hives. Kids 1 to 7 up to 25 milligrams, adults 50 milligrams, and you put it in their deltoid muscle. I suppose you could inject it in the mouth. I never have. I've seen 2 of these, and I injected in their deltoids. Both of them occurred because of a penicillin that we'd prescribed. The one called from the pharmacy and said, "Hey, I took one, and gee, I'm itching all over. I'm coming to your office," and I didn't get a chance to tell him to go to the hospital. At any rate, if it happens, terminate the appointment and get them to their MD, because they're probably going to be either on oral antihistamines or a corticosteroid for 3 to 5 days to be sure it doesn't recur. The fast onset allergy starts rash, hives, itching, sneezing, GI upset, difficulty breathing, swelling in the mouth or throat, really bad sign. Their blood pressure can just drop out of the bottom. They can lose consciousness. This happens really fast. You can't call 911 fast enough. In this case, you're looking at anaphylaxis, and even in the emergency room, when you see an anaphylactic reaction, some people don't make it. So you need help, and you need it now. This is where you break out the epinephrine. You give it intramuscularly in the thigh, very deep in the thigh, close to their major bone. Or you could give it sublingually, 0.3 milligrams, which is 0.3 cc's of the 1 to 1,000 epinephrine, and you can repeat it every 5 minutes. And something I've learned from my paramedics, if you ever have to give the epinephrine, you follow it with 50 milligrams of Benadryl. The half-life of the epinephrine is a couple of minutes, and the Benadryl has a much longer half-life. So when they see this, they give the epinephrine, then they give the Benadryl. You can give the epinephrine again. If they're getting worse, you don't have to wait 5 minutes. You can do it in 3 minutes. They need to go to the hospital. So call 911. Convulsions and seizures. As a Boy Scout, I learned you put a stick between their teeth, keep them from swallowing their tongue. Don't do that. Boy Scouts have knocked out a lot of front teeth trying to get a stick between them. The patient may become rigid. Their muscles may contract. A grand mal seizure, they contract violently. They definitely have altered consciousness or a lack of consciousness. If it happens after local anesthesia, you get a little suspicious that it might be a toxic reaction to the local, that you got it into a vein. Lean the chair back, get their feet elevated. Bring your staff in, and don't try to keep them from moving, because their movements can be very violent. You can tear muscles and tendons of the patient, or you could even have your staff injured. You just want to keep them from flopping out of the chair. If they vomit, try to turn their head, but certainly have your suction ready to go. Post-seizure, they may be very depressed, and you may have to work to keep their airway open. Chin lift, head tilt, particularly if they're snoring or in a very deep sleep. Listen for their breathing, and now it's time to get their vital signs. If it's their first seizure, they need to go to the ER. Now, we have 2 patients that have seized for us. One was a petite mal. She just sort of loses consciousness, but she doesn't appear to be unconscious. And within a minute or 2, she's back to normal. And she has these on a regular basis, so they don't have to go to the ER. The other one had had a benign brain tumor removed and was left with a seizure disorder. She seized once or twice a week. And so we knew what was going on. Her father was with her, explained, just give her a minute. She'll come out of it in a minute. Don't do the Boy Scout thing. Don't put anything in your mouth, particularly your fingers, because you could lose one. You can put a full face mask on and let them have some oxygen. They're not breathing effectively, so they're not going to get much oxygen, but when the seizure breaks, they're going to be breathing. You hold them to prevent injury. You don't try to hold them still. You hold them to keep them from flopping out of the chair, and be prepared to have to open their airway once the seizure's done. And you're going to have to orient the patient, tell them where they are, how come, and of course, terminate the appointment. Emergency kit, we're going to go quickly. That was really covered in one of the other videos. But you need a bag valve and mask. I now have cards with the name of the drug. In this case, it's a reversal agent for benzodiazepine. It's called Romazcom or Flamazanil. What does it do? It reverses halcyon. I need to give 0.1 to 0.2 milligrams, 1 to 2 cc's, and I can repeat it. The syringe and needles there, the drug's there, and everything I need to know to give the drug. Of course, you want to always be sure you have recent fresh drugs. This went out of date in 2001, so you don't want to have that in your emergency kit. Blood pressure is an important part of these emergencies, and we did a little study where we compared the sphygmomanometer and stethoscope with the automatic blood pressure devices and this little finger blood pressure device, and statistically we couldn't see a difference. Blood pressure is important enough that we need to, at a minimum, get a blood pressure at every recall appointment. They looked at 3,665 dental school patients in Mississippi. 32% were diagnosed with hypertension, 27% were undiagnosed, but they all had pressures greater than 160 over 100, indicating even those that were diagnosed were undertreated. They needed more medication. So we ought to know that before the patient sits down and certainly has anything done. And at least twice a year, many offices are taking it at each appointment. I think that's a good idea. But prevalence is great enough, often undiagnosed and uncontrolled, that it justifies routine blood pressure screening of dental patients. I found this chart, which I really like. It was under Vaughn's summaries. Do a Google search, and if all they have is a carotid pulse, their pressure is about 50 over nothing. If they have a radial pulse, it's at least 60, probably over about 10. But you can see here's a patient 140 over 90. That's high normal. Anymore, they're really wanting to see everybody below 120 over 70. But this is a good chart for your staff to have, and they can take the blood pressure and look at that and say, hey, we got a problem here. This patient is 200 over 110. We probably don't want to treat them today. You need to be able to support respiration. You need a variety of face masks. They should be clear because oftentimes patient will vomit. And you squeeze the bag, and you want a bag that you can hook up to oxygen. And you need a portable tank of oxygen so that you can take it into the reception room, out into the parking lot if necessary, if somebody decides to faint out there. I bought some practices in the late 1990s, one of the smarter and dumber things I ever did. Financially, it wasn't successful, but it taught me I didn't want to do any more of it. The problem is you need to have at least 5 or 6 offices so that you can just replace people when they're sick, when they're out for pregnancy, with 3 offices, one of which was very busy. The 2 other ones were quite busy. It was just too fast a game. But the first thing I looked at was their emergency kits. And so this one expired in 1979, and it was the only emergency kit in the office in 1099. So it was well past its prime. The other one had a bunch of drugs in it, but when you look at them up close, they've picked up the color of the stopper well past their prime. So I replaced the emergency kits. These are the pre-packaged emergency kits. They come with drugs that I don't particularly like. And I'd encourage you to take a look at the video on medical emergencies in the dental office, a complete description of this. I think we all should have automatic external defibrillators in our offices. That's to be expected. You'll find them in drug venues, in sports venues, in hotels, in airports. I think we can be expected to have one in our dental office. I actually brought one for our home. I'm old. I'm 75. I got a lot of old friends. And if one of us has a cardiac arrest, I'd like to be able to do something about it. They're not terribly expensive. Your cell phone is part of your emergency kit. Either Terrascon or I like Hippocrates on my iPhone. It works better. And I can type in up here in the search line what other drug I'm curious about, and it'll tell me about a half a page of information I need. The little old patient that comes in with 5 drugs they're taking, I cannot keep track of all those drugs, but I can enter 5 drugs in this really quickly. And I know if they're on a water pill and a beta blocker and a calcium channel blocker and an SSRI, hey, we got somebody who's getting close to heart failure and we better be careful with them. I can find out more about their disease by what they're taking than I can by asking. I had an elderly gentleman, he must have been in his late 80s, come in, and he was just there for a simple filling, but I looked at his chart. He was not taking any medicine, not even a baby aspirin. I said, "You don't take any medicine?" "Oh, yeah." He said, "I was in the hospital a couple of weeks ago. I'm on a couple of them, but I can't remember what they are." "Really? How long were you in the hospital?" "Oh, I was there a couple of weeks." And I said, and why were you there?" "Oh, he had a little heart attack." "No, no big problem. Nothing you have to worry about." Well, if they kept him in the hospital, he had more than a little heart attack. And I needed to know what those medications were, but I wasn't about to give him local anesthesia until I knew more about what had gone on. So this was my next uh, emergency kit. I had Valium in case I wanted a seizure, and that's kind of question mark whether you want to try to do that. So with Valium, you got to get it into a vein. You could use midazolam and inject it intramuscularly. I got epinephrine, Benadryl, aspirin to chew if they're having a chest pain or a heart attack, nitroglycerin spray if they're having angina, albuterol if they're having an asthma attack. Here's my reversal agent for the benzodiazepines. A can of non-diet soda, which is the best way to get people out of hypoglycemia. And notice the epinephrine here is in ampules. It's way, way, way less costly. Those ampules will cost you $2 or $3, and they'll work just as well as the EpiPen, possibly better because you'll keep them up to date, where the EpiPens now are getting close to $200 a unit, and you need at least 3 adults. Unless you're seeing kids, you need 3 kids also. So you're talking about $1,000 in EpiPens, and over 1,000, and you're going to have to replace them every 2 years. I don't think you need the Solu-Cortef now. If we were having an allergic reaction, they would be going off to their physician. Oxygen is one of our drugs. That's our 3rd drug. And if you're in California, you need atropine in your emergency kit. You notice there are no ammonia inhalants, and there shouldn't be. Ammonia is a very caustic drug. You don't want to be inhaling that down into the lungs. The only thing ammonia tells you is a patient is still conscious because they'll take a swing at you. It's such an obnoxious smell. But it's very damaging to lung tissue. You shouldn't have it in your emergency kit. I think a far better solution, if you're doubtful as to whether they're asleep or awake, is pinch them in the fatty part of the back of their arm. Pinch and twist. And if they're awake, they'll respond. And you didn't screw up their lungs. Why the back of the arm? Well, it happens to be a very sensitive area, and they won't be able to see the bruise. So I now have a printout of those drugs with a little more information, and I believe the syringe, needle, and drug should be taped to the card. Here's our albuterol inhaler taped to the card. Down here we have the nitrolingual spray. And I put all these cards in a large Ziploc bag, and that's a very good, easy to use emergency kit. I also have a tennis ball with 911 marked on it. Why the tennis ball? Well, it reminds me that it's okay to call 911. And if I've got something going on and I know I should give them a drug and I just can't remember what drug I've been suggesting people should be using for this reaction, but I know I got to give them something, and my goodness, I got to do something. I got to do something. I got to give them a drug. Well, read the 911. Tell Susie to call 911. And if you just got to give them something, draw it up in a syringe and give it to the tennis ball. That way, you won't make the patient's condition worse if you use the wrong drug. And you've called 911. I've got 4 or 5 patients who are paramedics in Seattle. And when they found out I was teaching this, they said, for crying out loud, tell your dentist to call us early. We end up going to dental offices on a fairly regular basis. And if we can get there while the patient's still alive, our save ratio goes way up. Uh, the sooner we get there, the more help we can be for you. And you don't get points against you for calling us. In fact, it may keep you out of trouble. So that's what the emergency kit looked like. I have some emergency protocols, one here for my staff. Anytime a person becomes unconscious or the condition seems to be worsening or they're having heart problems, call Medic 1, 911. You'll never be wrong by calling. You can only be wrong by delaying the call. And it gets hard to know things when that's happening. Here's our address and our cross street. I also have a separate sheet for anaphylaxis because that's one, if it happens to you, you need to be on your toes and get it taken care of quickly. So, you want to be sure when you're using local anesthetic that you get the tooth numb. Taking out this tooth, I needed really good anesthesia. That's a model I built for Children's Dental Health Week one year. So, can you get credit for looking at this presentation? Some states will allow you to claim credits for just watching it online. The case of the state of Washington, you just record it in your CE, and they'll accept up to 7 hours of online CV a year. But I'd encourage you to check with your board. If you're in Oregon, they want you to take a quiz about the information and have certification that you passed the quiz. So I've prepared a simple 10-question quiz for this presentation. The good news there is you email me, I'll send you the quiz. If you don't know the answer, you can go back and review the video again. It's free online, and you get the answers the second time if you missed them on the first time. To get the test graded and to get this letter of certification, I do charge $30 because that takes a little additional time. You email me, I'll send you the test with directions. You send it back to seconddentalopinion.com at that address, and I will grade it and send it back to you. And again, you can watch the video a second time. But if you have any other questions, here's my email address, fredq@comcast.net. I hope this was worth your time to watch this. And with that, I'll shut it off and say goodbye.